So there is us. You see us, but we've done this once before where you couldn't see us. So keep going, Kyle. These are boring. Yeah. So there's a little photo of the front of Greenwood Court. Just recently, we have a little extra property, and we've got a hospice on our property, not owned by us, but they donated the land. So it is on our sign
It's
as
on
well.
our site and sign. Yeah.
Yep.
So our home opened in 1994.
Wow.
And that's my daughter. She's doing screening. That's my
Oh,
daughter.
look at her.
Great.
Yeah. Both of my children work here. One's a PSW and one came on as a screener in crunch time,
Yes.
right? They both have helped out in crunch. Yeah. Next. Yeah, we don't need to look at Nicole forever.
So we're a very small long-term care home. We are 45 beds long-term care. We're divided into 2 units. We have a 30-bed unit, which we call colonial, and that bed's more of a medical, traditionally was more of a medical unit. However, over the last year, the level of dementia has risen on that unit, and it's become a real issue based on how the home was built, in the fact that our front entrance area is a beautiful lounge space that is their lounge. And so because of our outbreak, we've had to take that lounge space away, but we still have these residents with dementia who are now wandering in this area all the time. So that's become a bit of a issue. And then our 15-bed dementia care unit is a lovely, beautiful sized unit. We have a central lounge space. The dining room is not big enough for our resident care how we would like it, but all of the rooms in our home are private with the exception of 3 semi-private rooms. And even those semi-private rooms, they have their own living space with solid walls, and they share a bathroom. So really everyone has a private room to live in.
Marianne,
Yes.
Is this the way that most new homes now are, whether private or whether for profit or public?
Yes, so that's the new standards that you have to build to, but even a semi-private room can still have like a curtain divider between the beds, and they do that to save space, right? Cost and space. So our home is 26 years old, and they were very forward thinking when they built the home to invest in all private rooms, all private bathrooms,
Outdoor space.
the outdoor space off of each unit. Unfortunately, they didn't consider the level of care that people would be 26 years later, because the dining rooms aren't big enough to accommodate our big tilt recline chairs, things like that. And then there's no space for the lifts. A lot of new homes install ceiling lifts right off the start. Our home doesn't have that, so we take the mechanical lift to the bedside and then it sits in the hallway. We also have 2 additional rooms that were built at the time in hopes that at some point we would get more bed licenses. So they fall under our retirement license. We call them our non-funded beds. So often it's someone that we know of either from our community of care, because we also have 85 independent apartments attached to our building. So if we see someone needs surgery or someone is failing in the apartments, they can't get into long-term care because of the bed shortages, we may bring them into that non-funded bed, and we either they can afford the money.
Yes.
So they're there for either till they recuperate or till their name comes up and they move into one of our long-term care beds. We also have an 18-suite retirement unit, which is our 2nd floor above the colonial unit. And that's where our first COVID case actually happened, was in the retirement unit. And then we share space with Avon Mennonite Church. So our home is a not-for-profit home formed from the Oxford County, Perth County, and Waterloo region, the 3 counties Mennonite churches. So we share space with Avon Mennonite Church. So sometimes the church space is ours, and we use it not only for church, but for musical groups, for resident staff meetings, and other times the church obviously uses that space. So right now, as of March 14th, when our doors were closed to visitors, the doors to the church were also closed, and they haven't been on site either.
Next. There's some pictures.
Yeah.
Pictures speak 1,000 words. Some of our and PSWs and yeah.
So the top picture is actually one of our recreation staff doing a resident's hair because we also haven't had hairdressers in. So everyone has kind of stepped up and shared talents that they've had. The top right picture, thank you to the Heroes of Greenwood, that was made by one of our resident families.
Okay.
And this is just Nurses Week stuff. We've had lots of kids do pictures and yeah, it's sweet. Oh yeah, next, just a fun little. So we were in outbreak. I don't know if you knew that, Mr. Fraser, but we just actually got out on Monday. Yay, it was a very long haul for us. We were right at the beginning of the wave. So before we started the mandatory masks that RNAO pushed, but did not, the directive didn't come out till after we were in outbreak. So we had a total, I won't go through them all, you can just go through. We had a total of about 6 residents by the end, 1 in our loft and then 1 in our heritage unit. Likely the spread was a staff member that went between the 2 places. Then we had a larger spread on the heritage unit, which is our dementia unit, just because of the nature of the residents that live there. So we ended up with 5 total on the heritage unit and just the 1 in the loft, which I think we did fairly well with managing based on the units they were in, but it was 5 out of 15 in the heritage and then just 1 out of 17 in the loft. We were obviously able to isolate people better in the retirement home area. You can go to the next. So our last case that was positive was on the 5th of April, and then we had all the aggressive screening and we never passed it on to anybody else, which was the good news. Unfortunately, 3 of those 6 passed away. They did not have the strength to beat it. Or no, 4 of the
Actually,
6
we
did.
need to
I should have updated that. 4 of the 6 ended up dying. 2 kind of were strong enough to beat it. We were able to have the families in with them at end of life if they chose to be. I think one of those families chose not to because of their own health issues. And then in terms of staff, the staff was what went on the longest. That's the next slide. So I think we had a total of 10 staff at the end. And interestingly, we did the big swab on the 23rd, 24th, where we did all of the staff as directed. And everybody was negative then, except for the ones we knew of. And then on the 26th, like literally 3 days later, we had a positive staff, symptomatic positive staff, which was, yeah, so they've all been resolved and are back now, which is beautiful too.
Great. So you're not missing.
All of the staff were high-risk contacts, again, before we started universal masking. They had all had initial contacts with our first cases.
Yeah.
So it speaks to once we started universal masking and initiated full PPE and isolation, we were able to stop the spread of it within our home.
You guys have done a good job.
Amazing job, yeah.
Amazing.
And it speaks, we've got a few things and we'll touch on those few things as we go, I think in terms of what helped us. So, and I think what could help going forward, right, for long-term care, because if anything, I pray that we learn something from this.
Yes.
And that we actually take advantage of an opportunity, right? Like there's so many opportunities that come and go and then the next wave comes and nothing gets done. So
Yeah.
I just pray that there will be some positive changes for long-term care that come from this because we've been hit hard. So in terms of our facility, that's a picture of our front lounge. And a bedroom and a bathroom that we have that are private. That was the only way, and that's why we did as well as we did. One of the big reasons was because of our private rooms and our ability, our small units. Like, again, thank God it was on our 15-bed unit. I can't imagine the work it would have been on a 30-bed unit to do what we did, but that really saved us. The one issue that we will need to address still is our dining room. Like it's going to be, especially with the new rules about physical distancing, there's just no way we can manage our dining space with our current facility. And then there's the other little things in terms of facility, like if we're going to be using the negative pressure, right? Some extra added things that way as well. And again, the safe outdoor spaces are they've been a blessing for us because at least the residents in lockdown, like we're not multi-leveled. I don't know how they do it, those homes. At least they can get outside and breathe. We know how we all feel just sticking our noses outside. And then the other thing that's a beauty in our facility is that continuum of care. So we were able to support the retirement home section as well as we did because we had the resources of the long-term care section. So a lot of the management covers both areas, if that makes sense. I really feel for retirement homes through these outbreaks because they don't have even the resources that we have in long-term care. So yeah, the retirement home was able to just do exactly what we did in long-term care without any extra kind of push.
And we were able to staff up in that area because we could pull from long-term care and move resources to
And
make them
PPE
safe.
and
Yes.
yeah. So that continuum has really been helpful. And again, whether that's something looking forward, whether long-term care retirement homes should work more closely together to provide that care. I don't know how or what that would look like, but.
So in ECHO, we are saying, just for John's sake also and for yours, that both nursing homes and retirement homes need to come under the OHT model. Because right now they're not mandatory. So some OHT do have long-term care, others don't have. It all should be part of the mode of giving care.
Yeah. And in my last life, I worked in the community as a nurse practitioner with geriatrics, and they used me to round at the retirement homes in the community, which made a huge difference because you can totally prevent emerge visits. You see them declining. You can start the long-term care application sooner than later. So I did a ton of that in retirement home. That it really, I think they're a group of seniors that are on the edge that need more care than what they're getting there. But
and probably there are some in retirement homes that are more complex than the ones you have sometimes.
Very much so.
Listen,
And
your place is gorgeous.
Oh, yeah.
That place is gorgeous.
yeah.
So
And
much
as-
light.
Yes, there is.
Yes, we're very fortunate that way. All of the rooms, all of our long-term care rooms are on a ground floor. So everyone has a view and we have access outside. So as our first COVID case was in retirement, as he started to fail more, we actually moved him to our COVID unit, the Heritage unit, because we don't have the resources for registered staff 24/7 in that area. We have one RPN who works 4 days a week, a 6-hour shift. Myself and Wendy were here, like I think 11 days straight at the beginning of our COVID outbreak. And then we started to vary where Wendy would take a day off, I would take a day off. Our infection control nurse would take a day off, but still we weren't here 24/7 to support that person. So the decision was made that in order to give him the best death possible, he needed to be in the unit where we had staffed up our registered staff complement as well. So
The other thing we got to do through this, because you could throw away all rules, is no other physicians have walked into the building. So we used to have about
We have a nurse practitioner.
we have a nurse practitioner.
yes, but we had 15 physicians that used to provide care for both units.
And that likely 15 physicians equal one nurse practitioner.
Yes.
And so what I could do,
Sorry,
because,
that's on tape. So my
because-
apologies to the colleagues physicians. I meant 15 virtual physicians equal 1 in 50 time there.
and it's because I'm here, right? I'm on the ground. So I've been able to actually cover, the physicians have been allowing me to see the residents in the retirement home too. So
Those residents are lucky.
yeah,
They are.
On tape.
Okay, next
Now,
one.
Doris, that will be edited out, your other comment.
No way, Jose. Those residents are lucky. And
Oh,
I mean-
no, that won't be edited. I mean, the other
nothing
one.
will be edited. So John, just so you know, we didn't know one another personally before COVID with my colleagues, but Wendy and Marianne have been phenomenal in leadership. And Wendy also, we do twice a week meetings with the long-term care nurse practitioners. And Wendy has been, alongside Jane and a few others, really top role models for them. top role models.
Yeah.
Thank you,
Thank
Doris.
you.
It's true.
So our next item is resources on the front line. And being a small home, our registered staff are pushing the med cart. They're the ones doing the documentation, they're doing the assessments, they're calling the families, they're talking to the physician and the nurse practitioner, they're calling the pharmacy to get orders changed. So when our COVID cases happen, we have an RN 24/7 who works in our colonial unit, and then we have an RPN who works in our heritage unit 6:30 to 1:30 on days and 4 to 8 on evenings. So to do the assessments and our medication pass only. Well, when COVID struck heritage unit, we realized we couldn't have our staff go back and forth, and we needed to staff up that unit with 24/7 registered staff as well, in order to keep everyone safe and to meet the needs of the residents. But there's still that lack of the bodies, so the funding to actually have the support for the registered staff. Our first COVID case in our heritage unit, she started to seize when her oxygen levels dropped from COVID. And if Wendy hadn't been here, if it hadn't happened during the day where myself, the ADOC ran over, we're the ones who supported the RPN at that time. If it had happened in the middle of the night with one RN in the building, they're just, yeah, it's horrible. Yeah. And we look at the expectations that we give our registered staff from a ministry perspective, the ownership that is on them. It's no wonder people don't want to come and work in long-term care, and why nurses go to acute care, because you can do your 12-hour shift and leave. There's not that where you come in the next day and you had told the resident you were going to do something and you didn't do it. They're still there waiting for you. And we become their families, and their families have huge expectations of us as well. And it is, we work in long-term care because we love what we do, and it just becomes onerous at times, to be honest. And it's no wonder that our registered staff and our PSWs are looking to work elsewhere. The $4 an hour.
We got to change it.
Yeah, we have to change it. The $4 an hour that the frontline staff are getting as a pandemic pay, I don't think it does what it needed to do. We need to have more bodies on the floor. If we had been given that funding, we could have put extra PSWs to actually provide the care, versus we had 18 nursing staff walk out of the building when we went into an outbreak. Well, now they're ready to come back because our outbreak was declared over, because they still want a piece of that $4 an hour.
And if I may add, John, where you can also help us,
Yes.
I know Marianne is talking about the staff, and that's absolutely the case.
Yeah.
Also, just so you know, Marianne, who does direct care, and the director of nursing in the homes in general, who do direct care many times, they are not getting the $4. They're getting zilch. So actually, many of the nurses will make more income when really,
My nursing staff
no,
will be
when
making more
really,
than I am.
yeah, but when really the directors of nursing, John, and this is always, not just during COVID more, they are really 24/7 on the hook here, not just at the legislation, the access.
And here,
Yeah,
Here on
and
the
this
hook.
hook,
yes.
yeah.
Here on the hook, right? And many times physically there. Marianne was 12 days in a row working 14 hours a day. Same with Wendy, but Wendy will get it. I'm pretty sure, Wendy, because nurse practitioners will. In fact, I am sure. But Marianne will not. It makes no sense. So help us push.
So I'll just go really quickly. Called on the government to do this at the end of March, beginning of April. And really what we said is long-term care and certain aspects of community care, you've got two challenges. It's ground zero. It's where things are happening. It's difficult. The rates of pay there are lower, and it's hard work. And you need to stabilize your workforce. So you need to do it right now, just like BC. Do it now.
Yeah.
And the government waited, and then I don't want to be I want to be helpful, but they've really mismanaged the intent of what that's for, which is to to people who are really, really putting themselves at risk, long-term care, and to ensure that we can stabilize the workforce. And they waited too long. And in some circumstances, it made it really bad for some organizations.
Yeah.
I'm sure.
And we got help, but we got help 3 weeks late for
Yes.
our outbreak.
Yes.
So
Yeah.
we're great now. We've got extra bodies and we've just let the extra bodies stay because the hospital's paying them. But we didn't get it when we needed it. They were burnt out. Yeah.
Yeah, no, there's no,
To
yeah.
interrupt, I just want to be cautious of time. We have about
Yeah.
2 minutes
Yeah.
left before we have to jump off for our next
Okay.
call.
Okay,
We'll
but,
go
yeah,
through the next couple.
No,
PPE
no.
is huge. You
Yes,
saw that
PPE
there.
is huge. And the comment about housekeeping, there isn't the money to bring the housekeeping staff on. As Doris said, we have the skill, we know how, but we don't have the bodies to do the intense cleaning that needs to happen.
So we
Yeah.
think we should put a nurse practitioner in every home. That's just,
Yes.
And
Yes.
this is something,
We
John,
would-
that
we
we have
would.
been asking
Yeah.
for the
We
last
would not
10
have
years.
gotten through this outbreak without our nurse practitioner here.
So
We
we
had no
got from,
support
we-
from the medical.
Yeah, I think that's a very wise idea from just managing resident health across the board. There should be one in every home.
Yeah.
so there exists already, just so you know, I negotiated that back then with Premier McGuinty and then with Kathleen, and then it continued for a bit. So we have about 60 NPs in nursing homes as attending NPs. Now we need, and we have been asking, and it's again in ECHO, 120 residents across the board, because this, if the people that were not aware before, they are aware now.
Mhm.
Okay, so
So then the next one is our collaborative approach with regulatory bodies. We don't need more legislation. We don't need more punitive
regulation.
knocking us down. We are the most regulated industry in Ontario next to mining. Let us care for our residents, but support us collaboratively to care for our residents. During this COVID outbreak, how the ministry, we've had a collaborative approach. It has been wonderful. So let's build on that.
And then the last thing is I read a little tweet that Minister Fullerton said, which really disappointed me. And I think she said flat out that we were broken. The long-term care system was broken and that there was going to be a whole review. And I'm like, no, not another review. The Honorable Eileen Gillespie just did that in July 2019 and said so clearly we're strained, not broken. And I think if we just learn from that report and then through this, I don't think we need another review. We just need action.
I don't think-
Absolutely.
I don't, yeah, I'll take, we called for an inquiry, just as the other opposition parties did. And I think, like, that's for something down the road. Right
We
now,
don't need an inquiry, sorry, John. We don't need an inquiry, and I'm
Spend
saying
the
this
money
publicly.
on the ground.
What we need is to fund nursing homes the way they need to be funded.
I think what we're trying to drive at is the government's response in long-term care. And I'm going to say across, like, right now in the pandemic and before, you know, I think we have to look at that. I don't mean an inquiry to look into, it's not to do what we've done before, but we actually have to look at how do we respond in this pandemic in long-term care. And I'm working very hard to be, contribute positively to what's going on by, let's see what it is we need to do right now. But the response has been flat-footed. So it's like,
So John, there needs to be a review of the leadership in public health, with all due respect. At the highest level of public health, that's what is needed.
I think that's what we're driving at, is like, why did we make these decisions? And one of the questions I have is, when you had excess capacity in tests, why did you not actually use those tests to help in those long-term care homes that needed it the most, right? Like, let's not wait till we try and do everything, you know?
And when we were asking ongoingly, because our NEO, and you know, because we have spoken, John, we asked for, first, the nursing homes need the universal masking before anybody else. They need the testing. They need the human resources. They need to work in one employer, bringing them full time. And it took for quite frankly, Dr. Williams, a month after, until he started to give the directives.
Yeah, no, you won't get
Late in
an argument out of
that, yeah.
But I do want to say is I haven't been to Greenwood, but I have been on your campus.
Oh, okay.
So I was at the hospice in July, I think.
Oh,
Okay.
nice.
Nice.
So, because that's when I was in government, hospice was my file for 4 years.
Uh-huh.
Okay.
That was one of the hospices.
Yeah.
And
Yes.
And it's a
long-term care,
beautiful hospice.
and the next step we wanted to take, and we didn't get there, I thought we should take was, we needed to help support palliative care in long-term care because you're like big hospices.
Yes,
Mhm.
that's
Right?
what we are.
You know,
Yes.
Yeah, they're just a little, we don't have a 3-month,
No, but people are still palliative,
yes, yes.
Yeah.
right?
Yeah.
And
Yeah.
so, anyways, you have my full support. I'm probably going to have to jump. I have to jump on another
Yeah.
Zoom call.
I think we all kind of do, and
Yeah.
I think we should let you know it probably is time to wrap up, because I know it's after 3, and
Not without a clap to John,
yes,
to
Yes, thanks, John.
Wendy,
to
and
everyone.
to Marianne,
Yeah.
and to all of you, and Kyle
Everyone.
for organizing. Thank you.
Thank you.
Thank you, thank you very
Happy
much.
Nursing Week.
Happy
Take
Nursing
time.
One last thing before we go, ladies.
Make sure you clap yourself and you
Okay.
celebrate, because you guys are
Yeah.
really leaders,
Pat yourself
super
on the
leaders,
back.
super leaders.
Ladies, you've done a great job in managing it in very difficult circumstances. And that's what's made the difference in those homes where they've been able to
Yeah.
manage the not, it's not like you're going to avoid having one. You're going to have one. How do you manage it? And we've got some really serious situations like we do across the province here in Ottawa, and where things didn't get managed. That's not a criticism. The support wasn't given that was needed when it was needed. And then people became overwhelmed. And once you become overwhelmed, you can't make good decisions.
Yeah.
And so I want to thank you, and I appreciate you guys taking the time. Good to see you all.
Thank
to see you, John,
thank
and good to see you,
John.
colleague.
Thank you,
Take
everyone.
care.
Take
Bye-bye.
care.
Bye.
Bye-bye.
Bye.